For many of you, welcome back from our first General RAC this morning. This is the second General RAC of our CCO 2.0 Rules Advisory Committee process. We have a number of people in the room and on the phone. I will remind everyone this is a public meeting. It is being recorded. We do anticipate posting an audio file or recording of this meeting in the next week or so to a website, as has been requested. So again, welcome. My name is Ralph Magrish. I'm a policy analyst with the Health Systems Division here at the Oregon Health Authority. I will make a few brief remarks. I will condense them from this morning's session and just keep to the salient points of context for those of you that are joining us for the first time, to give a little bit of history as to this process, what's come of it, and where we are going. Briefly talk about the process for you as RAC participants today, and we welcome members of the general public in the back of the room and on the phone. So again, good morning, good afternoon. Thank you for being with us. Just a little history. This rule rewrite and revision came out of the recognition and need of the existing rules as we move towards CCO 2.0. That the existing framework was not sufficient to support the new rules necessary to implement going forward, and we made changes to improve readability and alignment with contract. We had great support from the Oregon Department of Justice in this engagement, so we thank them for that support. Very briefly, I think if you have not observed already, you pick this up fairly quickly, and hopefully all of you are pleased with it. We've made significant efforts to improve for readability and minimize repetition of rules. That includes edits for brevity and clarity, removing duplicate content, renumbering other rules, and removing and correcting citations that were inappropriate, and renaming rules where appropriate. We've also moved from a construct of definitions, of broad definitions, to local definitions. Angel, can I ask you to join us at this end? Yes, thank you. So I think, do we have copies of the RAC participation sheet that have circulated around? I think there's some on the table, if helpful. But what we're doing with this project, thank you. So we've got a pretty aggressive agenda, as those of you that participated this morning noted. We made pretty good time through it. As a procedural matter, all of the current rules will be repealed effective January 1st, 2020. The new proposed rules will come online that very same day. So therefore, we are terminating forever the existing rules. So as a process, we are standing up new rules. In the name of transparency and being open in what we're doing, we are bringing those new rules to this Rules Advisory Committee today, even though there may not be any material or substantive changes to them. We will speak to them very briefly. We will, as time permits, open for questions on them. But at the same time, we'll ask people to acknowledge or recognize that they are not substantial changes, and we will allow for comments to be submitted in writing later, which I'll speak to momentarily. So we do have a pretty large group with us today. I think we also have participants on the phone. The process for managing the meeting, myself and our subject matter experts will present and the rule or the proposed change as it is. For individuals in the room, we will get by raise of hand who wants to get in the queue to speak. Similarly, for RAC members on the phone, we will ask who wishes to get into the queue to participate. We will try to alternate back and forth between phone and table. We will ask you when you have the microphone, please use the microphone and state your name and the organization that you are speaking on behalf of. Also ask, just so I don't forget, anyone and everyone to please turn your cell phones on mute or vibrate at this time. And process-wise for the RAC itself, in comments submitted, again, trying not to be repetitious, but very important for people. Those of you participating today, in addition to the comments that you offer today at this meeting, you will be able to offer written comments within 7 days of today's meeting. So by close of business next Tuesday, if you are going to submit written comments as follow-up, we need those to hit the CCO 2.0 rulemaking inbox, the very same email address that you reserved to participate today. We will ask one additional favor of you, and that is in the subject line. If you're offering your comments specific to this RAC today, please put in the subject line RAC member participants or RAC comments for RAC General RAC number 2. That will ensure that we capture the right notes in a timely manner to review them. A couple other pieces. Again, this is a public meeting. We will have a 10-minute public comment period at the end of the meeting. We will take a break at mid-course, at which point I will go to the back of the room and ask if there are any members of the general public that wish to submit comment, as well as individuals on the phone who are not members of the RAC to do so. We'll take a list of them. That will be a 10-minute allocation. So if there are 5 people wishing to speak, each will be allocated 2 minutes, etc. And then some very important time frames that I will speak to for everyone's benefit for the output of comments received. The Health Authority will take the next month or so to synthesize and review all comments received and make adjustments to the rules where appropriate to do so. And on or about November 1st, the final version of the proposed rules will post on the Secretary of State website for a public comment period from November 1st to November 18th. There will be a public hearing on November 15th that people can come and offer oral testimony or additional submission if necessary or if appropriate. And the rules will take place on January 1st, take effective date rather. I think that's it. We've asked folks to turn off your cell phones. Let us go ahead and start with introductions in the room to my right, and then we will go to the phone. We're going to make sure so that Kim has time to capture people's names. One, we ask you to speak slowly, clearly, the organization that you're from, and I will make eye contact with people around the room just to make sure that Kim is ready to go. So if we can start over here. Mr. Buska.
Hi, Bill Bushka with IHN CCO.
Okay.
Sean Parkman, SCIU 503.
Jeremiah Riggs, BK working Columbia Pacific CCO in Jackson Care Connect.
Jessica Adamson, Providence Health and Services. I'm here for Christine Downey.
Oh, okay.
Thank you.
Yep. I'm behind you.
Dana Jorgensen, Hudson Medical Services, representing ORTC.
Kersey Kirk-Lewis, ORTC.
Thank you. Okay. Next.
I'm Stan Gilbert, Community Mental Health Director for Cloud County, and I'm representing the Association of Oregon Community Mental Health Directors. I'm Nick Gross, Eastern Oregon CCO.
Cynthia Ackerman, Home Care CCO.
And Ford Options for Southern Oregon.
Victoria Kelly, Recovery Outreach Community Center.
Micaela Suarez, Program Integrity Audit Manager.
Yeah. Okay. And if there is anyone that's a participant in the RAC that's in the back of the room, please do join us as there are empty spaces at the table.
Rich Jenkins, the OHA Administrator for Program Integrity.
Okay.
Dana Sterringer, Willamette. Rachel Arnold, Culture of Oregon.
Julie Spirit, Quality Health Alliance.
Alexa Lundgren, Cedar Hills Hospital.
Jared Hefner, Salem Health Hospital Clinics.
Jared Hefner.
Jane Hennebeck, Pacific Source.
Jane Hennebeck.
Jessica Sayers, Pacific Source.
Jessica.
Robin Traver, Umpqua Health Alliance.
Rachel Hungerford, Legal Aid Services of Oregon.
Thank you.
Englander, Oregon Law Center.
Michael Sorensen, Healthcare for All Oregon.
Laurel Swordlow, Planned Parenthood of Columbia Willamette, and Planned Parenthood Southwestern Oregon.
Thank you, Laurel.
Melissa Hanks, Deputy Project Director for CCO 2.0 for the Oregon Health Authority.
Lisa Croyce, I'm an analyst with the Transformation Center, Oregon Health Authority.
Tiffany Regan, I'm Member Communications in our External Relations Division at Oregon Health Authority.
Megan McClure, CCO 2.0 Project Director, Oregon Health Authority.
Gowinia, Hospital Program, OHA.
Thank you, Angel. So a little bit about process improvement. We learn a little bit new every day with that. So we're going to try one new thing right now, and that is rather than have our participants on the phone all blurt their names out at the same time, Kim is going to take a roll of phone participants. Also, in the name of process improvement, for those of you joining us later in the week, beginning tomorrow morning, we will have table tents available with your names. So we look forward to that for you. Kim, go ahead.
Joelle Archibald, John Curtis, should be on the phone.
John Curtis, are you on the phone?
Let's try this.
To request a specialist, press to place all participants. All participants are now in interactive talk mode.
John, are you on there?
This is Joelle.
Oh,
This is Joelle Archibald.
Thank you, Joelle.
John Curtis, Emily Farrell, Annette Fowler,
Here.
Heather Jeffries, Dana Jorgensen.
Here.
Thank you. Nancy Rickenbaugh.
Here.
Ashley Smith. Alexica Tucker. Nancy Wood.
I'm here.
All right, thank you. All right, so we will begin today with 410-141-3550. That is resolving disputes between CCOs and the health authority. Again, as mentioned, I will speak to those rules that have had minimal changes or not substantive changes for the record, as they will be new rules, and we will speak to changes that occur that could be construed as material or substantive. To that point, in this rule, the only change, and I repeat, the only change, is the addition of the last sentence in number 6. I will read number 6 in its entirety out loud. We will open for input, comment, or discussion if warranted. If the dispute is likely to impact another CCO, the authority shall notify all CCOs potentially impacted by the dispute and provide an opportunity for the impacted CCOs to participate in dispute resolution process. New sentence. CCOs that opt into the process have, from that time forward, the same rights and responsibilities as the CCO that initiated the dispute. Can I ask if anyone, I'm seeing some affirmative head movement in the room from a number of people. Can I ask if there's anyone in the room that wishes to speak or offer comment or input? I am seeing no hands. May I ask if there are any RAC participants on the phone that wish to offer comment or input?
Nancy Rickenbaugh.
Go ahead, Nancy.
This entire section has CCO rather than MCE.
Thank you very much. We will take a look at that. Appreciate. Yes.
Sorry, I didn't raise my hand earlier.
It's okay.
So that was a question that I had, because you also mentioned that there was going to be a lot of rules being repealed. And there are some rules that are still in the 141s that refer to non-CCOs. And I'm wondering, is the intent to turn everything into an MCE and then only the MCE rules apply? Or will there still be rules in the 141s that refer to non-CCOs?
Sure. So I think everyone probably heard the question. Broadly speaking, we've used the term MCE, managed care entity, which is the federally recognized term, pretty broadly throughout the rules. It is our intent that wherever appropriate to use the term broadly as in applicable to any type of managed care organization, be it CCO or DCO, etc. I think in specific cases it is going to be appropriate for us to use CCO, and what I'm hearing is we may need to take a look or get some comments or input from all of you as to your thoughts on the appropriateness of casting a wide net for the entirety of different managed care entities. So can I put that back to you in the form of a question?
Yes, so you would like us to submit comments about which rules we think should be applicable broadly.
If you would like to do so, yes. Or if you'd like to share thoughts with us today, you're welcome to do so.
I don't think I can do that very succinctly.
All righty.
So I will wait and do it in writing.
All righty, thank you. Other individuals in the room or on the phone specific to this rule and this rule change? All right, moving right along. Our next rule, 410-141-3555, resolving disputes between healthcare entities and CCOs that concern contract award. What we've done is to rename this from process of resolving disputes between healthcare entities and CCOs that concern CCO formation, certification, and recertification, given we are not using a process of certification or recertification anymore. The only change in this is found in number 5, and that is a quick correction to a statutory citation. So unless there are any specific comments or questions related to the language in this rule, I'm seeing Cynthia Ackerman at the end of the table. Just one second, I get a show of hands from other individuals in the room wishing to speak to this. Anyone on the phone? Cynthia, the floor is yours, and then we'll go to Robin from Umpqua.
If it's just the name of the rule, instead of contract, I think it should be contract.
How about that? I thank you.
Please repeat the question.
The question, the comment more specifically was pointing out to us what I think was a typographical error in the name of the rule, and that it should be resolving disputes between healthcare entities and CCOs that concern the CCO contract award. More or less a housekeeping piece. Thank you. And Robin.
Robin Umpqua. So I have a comment and then a question on section 1. My comment is under small c, big B. This might create a slippery slope, especially if CCOs are trying to strategically carve out certain providers to have a more efficient network. And then under big C.
Yes, may I ask for you to expand upon that? I'm not sure that I'm following on. I want to make sure that our team capturing comments today gets this right.
This is a comment from someone in my organization, so I can follow up written comment
Okay.
if you want to elaborate on that.
Please, thank you.
And then there was also the question for big C, what is OHA's process to identify whether the HCE is necessary or not?
Okay, that we will take offline and respond in writing to. And other individuals on the phone wishing to get in on this piece of conversation. All right, moving right along.
Can we ask people on the phone that are not, if you're not speaking, to please mute your phone?
All right, 410-141-3560, resolving contract disputes between healthcare entities and CCOs. There were no changes to this rule other than some minor edits for readability and, again, correction of a statutory citation in number 4. So with that said, does anyone have any questions or comments they would like to offer specific to this rule? All right.
Ralph, is the intention that wherever it says CCO now, that it'll be changed to MCE?
I think we're going to go back, and so the question for the benefit of everyone in the room and on the phone was, is it our intention to go back and change everything from CCO to MCE? I think we're going to need to go back and look at those on a case-specific basis and determine the appropriate applicability to each environment. On SEIU.
I heard you say that MCE is a broader concept.
Correct.
CCO is more specific.
Correct.
So if the rule needs to be broader, then
so what I would respond is that the dental care organizations have their own contract, managed care entities, CCOs have their own contracts. Some of the language that may be relevant to a CCO may not be relevant to a DCO or vice versa. I think we need to go back with a fine-tooth comb and just make sure that we've got all of that right. Thank you for that. Any additional comments? All right, getting past the easy ones, everyone. Our next rule will be 410, 141, 3565. This is managed care billing. We've got a good cast of our team members here to participate in conversation. There are a number of revisions here. Specifically, I will tell you what they are at a high view. We will open for questions from there. There are revisions related to coverage and mental health parity, consistent with Oregon Health Policy Board recommendation number 29. There are additions related to language of qualified directed payments for hospitals per Oregon Health Policy Board policy option number 12. There are revisions relating to the roadmap requirement since the original posting of the RFA, and changes related to Medicare claims billing. Would anyone like to offer question or comment? The bulk of the changes pick up on the third page in 8HI, or little I, and pick up in full earnest in 9. The I. Go ahead, Robin.
Robin from Umpqua Health. Under section 11, little a, big B, the covered service delivered in good faith, our claim lead stated that this would need to be a claim adjudication edit. So it's not possible to make a good faith into an administrable edit. So she suggested removing that piece.
I hear a suggestion or request to remove it. Mary Durant, our encounter data person, is that a comment that you would like to respond to?
I think we can look at it
Okay.
and see, make sure we're following.
Could you help me plug in my phone?
I'm sorry, sir, if you're able to go on mute, we would appreciate it unless you'd like to speak to this specific rule topic. Okay.
Can you please repeat what was said by the participant?
Robin, go ahead.
Yeah, under section 11, little a, big B, the ancillary covered service was delivered in good faith without the prior authorization. There's a suggestion to remove this piece because this would need to be a claim adjudication edit. It's not possible that we know of to make a good faith, to translate that into an administrable edit.
Okay. Thank you for that comment. We will evaluate that. Cynthia Ackerman at the end of the table.
Yes, Ralph, this one is under 8. I believe it's big D, little h. And this one has to do with may not delay or deny payments for the therapies provided for a child with an IEP. And I guess we pay for those, but there's also a coordination of payment because the schools do receive monies for those therapies. So I guess a little more direction or clarity on when that
Hits.
When that occurs.
Okay.
Because we should be the payer of last resort if there are other funds for a school provided therapy.
Understood. Thank you for that comment. We will evaluate that. Anyone else in the room? Yes.
Jessica Adamson. Jessica Adamson with Providence Health and Services on section 12, sub A. My assumption is that between sub 12 and sub 14, right after sections, that there's supposed to be 2 sections. So sections 12 through 14. Right now, there's no punctuation there, so I'm not sure whether it's just 12 and 14 or 12 through 14.
I apologize, Jessica. Where are you specifically?
So, third page in on the rule.
Okay.
Halfway down the page, subsection 12, sub A, reads sections sub 12, sub 14. It appears that there's punctuation missing between those 2 numbers.
Gotcha. Thank you very much for bringing that to our attention. Any other RAC members on the phone that wish to get in? We may have had to open the line out of necessity to the general public. To speak privileges, I'm not certain, so I'm going to ask that only individuals who were acknowledged for on the roll for being RAC participants on the phone, did you wish to get in the queue for this? Okay. Beth Englander from the Oregon Law Center.
Thank you. So, I may be going back a little bit, but, let's see, in 8 sub A sub large D, that you're asking for a requirement that written notice of the decision with appeal rights be sent to the member when the determination is a denial of the requested service as specified in the member appeal agreements rule.
Yes.
And I guess I had some concerns in the appeal and grievance rule. There are some provider-only appeals, and I think it needs to be really clear in rule that if billing is being rejected, that the member who's the subject of this at root is always getting notice. So I can't tell from this whether that's true. If it's not clear to me, then maybe it's not clear. But just to emphasize that any rejection of billing notification needs to go to the consumer.
All right.
Or the enrollee.
All right. Thank you for that. Yes.
And then in 9 sub little c, you're acknowledging that or if this is a reminder that cost sharing billing, like balance billing is not okay. So I guess C and D, balance billing is not okay, but referring exclusively to Q&B and Medicare. And I think it's important to add in a reminder in the rules that billing for any service that's covered by Medicaid is not appropriate unless the specific consent form was signed, and ask the CCOs to be reminding the providers about that. So that in the last RAC, referring to a different rule,
sure.
But I think it's an important enough issue that if it's in the rules in multiple places, I think that's fine.
Okay.
That's better.
Appreciate that comment. And we'll continue with Beth, then we'll go to SEIU, and then Dana in the back of the room.
I'm up to 18.
Okay.
Coverage of services through the benefit package. It says is limited by excluded services and limitations for OHP clients. I think maybe limited is
clearly a
is
omission.
with law, yeah.
Thank you for bringing that to our attention. All right, the gentleman from SEIU.
Sean Parkman, SEIU. So under 14, subsection E.
E, you said?
E.
Thank you.
Inpatient and outpatient reimbursement rates shall be calculated separately. Is kind of an understatement. So just given the amount of work that has been going on about site of care and hospital reimbursements versus inpatient versus outpatient and so on, I'm just bringing that up as a point to consider. Maybe OHA just think about whether that needs more specificity there.
Okay.
Just given the amount of work about differences in charging and between different sites of care.
Okay, thank you. And we had one other, go ahead, Dana.
So I just want to clarify that there are rules actually around providers being notified that they can't bill clients. I mean, there are already protections around provider contracting, and that's something that does talk to that specifically. But I also want to point out that there is a specific rule that allows providers to bill clients for covered services. So I also just want to caution that we've kind of been this blanket, it's illegal to do this when it's actually not. So I just want to be clear, I just want OHA to know to keep that in mind as they're considering that.
So if we are to do this to note any caveats or exclusions allowed under state or federal law that may allow billing to a client under very narrow and specific situations, and that those should be defined. Thank you for that comment. Can I ask if there's anyone on the phone that wishes to follow up that is a signed up and listed RAC participant today? All right, anyone else in the room that would like to ask, question, or offer comment specific to this rule? All right, we will move along to new rule, proposed rule 410-141-3570. That is managed care encounter data reporting. I'll give you just a quick summary of this, and we have our encounter data unit manager with us as a subject matter expert. We will note that these changes also implement Oregon Health Policy Board recommendation number 31. MCEs do retain liability for certifying encounter data as being complete, true, and accurate. This rule does apply to all managed care entities. With that, I will ask Mary if she wants to say a few words, overarching words, and then we can open.
I think we did, oh, sorry, so loud. I think we did, not know
It's a second for it to, there you go.
Am I good?
You're good.
Okay.
You're better than good.
So there was some cleanup that needed to happen in this rule because there was some old language left that talked about submitting 50% of what was adjudicated each month in that month. And we actually, in process, changed that already and updated the contract to say that it's really just everything has to be submitted within 45 days of the date of adjudication. So this cleanup was to remove references to that 30-day rule and leave us where we are with the 45 days, which is part of the mega rule, the managed care rule. So that's really the change. It does appear to be substantive, but for those of us in that work, that's what we were already doing, was the 45-day. And you'll see that in the contracts as well. Now they will be in alignment, where this rule was actually out of alignment with that.
And this is captured in 4A and B. And we're welcome to take questions or comments. I see one hand in the room. Can I see other hands in the room that will wish? I'm seeing two hands in the room. Anyone on the phone that would like to speak to this? All right, go ahead.
Robin from Umpqua Health. Under section 4, small b, and then large c, there's a time frame on adjusting or avoiding encounter claims within 14 days. And we would just like to request that the OHA consider changing that to a 30-day time frame, just because of the challenges in operationalizing this, especially for smaller CCOs where we have one FTE that's kind of dedicated to doing this work.
Okay, thank you for that. And go ahead.
Jessica with Pacific Source, related to what you just mentioned about the encounter claims in section 4, I would like to recommend that we add valid unduplicated encounter claims to that sentence as previously stated in the 2019 contract.
And thank you for that comment. Appreciate it.
And I have one more.
Sure.
It's another section, section 4, little b, big B. This is talking about how we must make an adjustment to any encounter claim within 30 days of discovering that data is incorrect. We would like to recommend that we change that language to within 30 days of correcting the discovered issue. If we have a system delay, a system issue, or some sort of a platform thing that we need to fix through IT, that may take longer than 30 days, and so we just would like you to consider the correction part of it.
Thank you. We will take that under consideration. Anyone else in the room or on the phone wishing to speak to these proposed changes? Okay, we will note that in 4B, big F, that is where the other statement was added. MCEs retain liability for certifying encounter data as complete, truthful, and accurate, consistent with contract. Last chance for anyone in the room or on the phone to offer comment or input specific to this rule. although not really last chance, because as stated, you will have the next 7 working days. 7 days.
7 days.
Calendar days. Thank you very much, all of you. All right. We're going to move on to a series of marketing rules. We have Tiffany Regan with us as our subject matter expert from our communications part of our external relations division. We're obviously doing very well on time. I will tell you that there are very few substantive changes in these, but we will run through them and we will open for discussion as we are committed to doing. So we can, to an extent, take as much time as necessary on these if that's where the conversation goes. If not, we will plow through and potentially some people will get some of their afternoons back, which I don't think anyone will be too upset about. So we'll move to 410, 141, 35, 75. Couple pieces to that. Obviously a name change, obviously notating that we have kind of segmented these rules, all the marketing specific rules, into one kind of domain, if you will. In terms of definitions, we've added or relocated definitions from other areas of alternative format, non-prevalent English language, and readily accessible. And we have consolidated some material relating to dual eligibles that had been in other rules. Are there any comments or questions? Let's get by a show of hands. I see 1, 2, 3 in the room. May I ask if anyone on the phone will wish to speak? We'll start.
John Curtis.
All right, John, why don't you, hold on just a quick sec, John. Are there any other individuals, RAC participants on the phone wishing to speak? John, why don't we start with you on the phone?
Okay, just one short one under 1A. It mentions sign language interpretation. My concern is for those members who might have limited English proficiency and how that would be captured.
Okay, thank you. And we are capturing that itself. Thank you very much. Any other individuals on the phone before we go to the room? Let us go Jeremiah Rigsby, then Beth Englander, then Bill Buska.
Go ahead. Thanks, Bill. Jeremiah Rigsby, Care Oregon, Columbia Pacific, and Jackson Care Connect. This actually may have been in the rule that we worked on a few years ago, but 1C, marketing means any communication from an MCE to a potential member who is not enrolled in the MCE. Does that cover areas where there's 2 MCEs? So just, do you want to take the out, or it should be that you don't want communications from an MCE to a potential member who's enrolled?
I cannot speak to that with a high level of confidence.
Is it too particular, I guess? Is it too specific to just potential members who are not enrolled in that MCE? I guess that's probably not. But, yeah.
Thank you. This is Tiffany Regan with OHA. So I'm going to take that back and get more specific on it, but I think you're right. I think we'd like to research that a little more.
Okay.
Yeah, thank you.
And then let's go to Beth, and then we'll come back over to Bill. And I am seeing, can I just see by another show of hands from after Beth and Bill, then I'm seeing Pacific Source and, sorry?
My name's Michael.
And Michael. And then I think we'll be heading down to the end of the table. So first Beth.
Thanks, this is Beth from OLC. I have a question about sub H. The definition of prevalent non-English language. The two, sub A and sub B, have exact amount, numbers of people who speak the non-English languages that are triggers for some actions. How will the CCO know that percentage? Where is that found in this rule and I didn't notice it, or does there need to be added in details about how that should be determined?
That's something that we currently have internally through OEI and our data health analytics folks. But let me take that back.
Okay, because it's everybody starts out in fee-for-service, so maybe you get that information and it needs to just get transmitted to each CCO. But I think that it would be good to get clarification.
So, Beth, to do a listen check, are you asking / requesting that there be some threshold as to what the tipping point is, if you will, to a non? I just want to make sure we're capturing.
I think these are the thresholds and
Okay.
tipping points, but what is not clear is how the duty of the CCO to investigate, to find out whether they've met that tipping point threshold.
Gotcha. Thank
Or,
you.
or how they would get that, how they're required to get that.
Thank you. All right, we'll come back over now, I think, to Bill, and then we'll work back towards Jessica and that end of the table.
I'm gonna pass.
Pass. All right.
Can I clarify my question? Just in case, just for Bill.
Yeah.
I'll give
Sure.
you my time.
To be clear about mine, are we allowed to market to the members that are in our CCO? So can we target marketing materials if it's not a potential member because they're in our MCE? That's really the question.
Okay. What's that?
I do that.
If you would like,
Yes.
so like to jump in there. So we will verify, but I believe it's specific to potential members.
Okay.
Yeah, but we can verify that for you.
All right, we're going to go to Jessica, and then I think we had Dana, and then I'm seeing Cynthia Ackerman after that. And I'm going to ask folks again, apologies, because I know people by first name basis, please do state the organization that you're with for the benefit of everybody else in the room and on the phone.
This is Jessica at Pacific Source again. This is related to Beth's comments on the threshold for LEP on section B here where it says 1,000 of the MCE members. The CFR actually says a significant number of members, and per CCO region, significant has a different meaning. And so I'd like the OHA to reconsider that number specifically and maybe remove that and leave it at a percentage.
Okay, thank you for that comment. And I'm also realizing that I passed the gentleman in the blue shirt over here. We will come back to you after the end of the table, and then we'll make it this way. All right, Dana, did you want to go? And then Cynthia Ackerman.
Yeah, mine just really quick, so under H.
And Dana, please again.
Oh, sorry, Dana Sterringer, Willem Delaware.
Thank you.
So I think A and B probably need to be different markers than we like.
And can you say that again? Sorry.
Sorry, I'm under H, still prevalent non-English.
Okay.
A and B probably need to be I and 2I or something like that. Right, anyway. And then under E, outreach, they're referring to outreach activities include but not limited to active raising the awareness of the CCO. And it's worded awkwardly, and I think what they're meaning to say is raising awareness in the community of the CCO's existence. But should that also be MCE, not the CCO?
We will take a look at that, I think. Thank you. Go ahead. Cynthia?
Yes, I'm Cynthia Ackerman from All Care CCO. 3 little b. That seems very, I guess it's a comment, the second part of the sentence, that express participation in or support for an MCE by its founding organizations or its subcontractors, so long as the communications do not constitute an attempt to compel or entice. And that's vague. I think it's vague and very subjective.
And I thank you for that comment. Cynthia, would you wish to propose or suggest any kind of alternative language at this time?
I'm not sure it even needs to be there.
Okay.
I think it's clear with the first part.
All righty. Thank you. Dana, I got to follow the queue. I think we have Sean from SEIU and the gentleman over here. And actually, I'd like to go to him because I think I skipped him before. And then, Beth, do you wish to get back in the queue after these folks? Okay.
1C, marketing.
And apologies, name and
Michael Sorensen, Healthcare for All Oregon.
Thank you, Michael. Appreciate it.
It looks like the conversation is about, or the writing is about brand recognition, and I'm wondering if this applies to things like bus routes, billboards. Is that what you mean by marketing materials that generally allow people to understand that this is an organization that serves Medicaid eligible individuals, and if you're not one, you should check this place out?
Tiffany,
Am I
is that a
making the right
question?
crosswalk or no?
We can take, hello, sorry, we can definitely take that back.
Compel or entice.
I hope not.
That's it.
All right, Sean from SEIU, and then we'll circle back to Dana Steringer.
Sean Parkman, SAU. So I have a general comment, which I know is not super helpful for the rule writing process, but just for
Your
OHA.
comments are welcome.
Okay, so the intention of my comment is really about this concern that having or more than one CCO in one area might lead to an unhealthy amount of resources being spent on competing with each other for attention versus serving the members. So as far as I can tell, and I might just, maybe this is handled somewhere else in contracts or something, I don't know. There doesn't appear to be rules kind of establishing, like limits on, theoretically marketing should be for the intention of helping clarify information for the consumer so that they are connected with some Medicaid services rather than a lot of energy and money being spent, like ours versus theirs. So I'm just adding that as a cautionary comment that maybe OHA should consider, thinking about some rules around, some limits around competition type marketing versus marketing that's more directed at consumer, that benefits the consumer directly, or like limits on spending or whatever it is.
Okay.
So that a lot of public dollars aren't ended up being spent on brand marketing.
Okay, so a summary statement, potential or to address, consider limits around competition-based marketing in geographic areas where there is more than one CCO, more or less.
Yeah.
All right, thank you. And we'll come back to you. Let's go back to Dana briefly, and then over here.
So to kind of piggyback on Cynthia's comment, under 3, the following communications are expressly permitted. It seems like that's referring to what is defined earlier in the rule as outreach. And it seems like it would be helpful for OHA to refer to its own defined terms in the rules that they're trying to describe more about how those terms are being used. Outreach shows up a lot in rules and contracts, and so if we're going to be using that as a defined term, I would like OHA to also use it as a defined term when they're describing the kind of activities they want the CCOs or MCEs to do.
Thank you for that. All right, and one more in the room here, and then, well, 2 more in the room, minimum 2 more in the room. We will go over here and then back to Pacific Source, and we'll do a check-in on the phone to see if anyone wants to engage.
Yeah, Jessica Addison with Providence. Section 3, sub B, that seems to be engendering a lot of conversation. I think from our perspective, it would be helpful to have some sort of language like that in the rule for that to stay. Because that provides cover for organizations like Providence. We're a founding partner of HealthShare, for us to be able to say in a public communication that we're a partner of HealthShare without that being perceived as us trying to somehow improperly market or outreach when we just are aligning ourselves with that organization.
And thank you for that comment. Appreciate. All right, and Jessica, Pacific Source.
I have Jessica, Pacific Source. It's real quick, I promise. Section 4 and Section CE are duplicative. I would recommend, 6E. I would recommend removing 6E.
Thank you. And can I do a check-in on the phone to see if there's anyone else, enrolled RAC participant, wishing to offer comment or ask questions specific to this rule? Thank you. All right. We are going to move along to our next. Did I see a hand go up? Nope. All right. Our next marketing rule, 410-141, 3580. This is MCE member relations, potential member information. This adds language specific to staff training, per Oregon Health Policy Board recommendations numbers 19 and 21. Those are identified most notably in number 7 on the last page of the rule in sub B and sub C. I don't need to read them out loud to you, but we'll let people pause for a moment, read that, and open for questions or comments. And may I see a show, actually, first may I see a show of hands in the room of people wishing to speak? All right, I'm seeing 3. Can I do a check-in of RAC members? 4 in the room. May I do a check-in of RAC members on the phone? If you wish to speak.
John Curtis.
All right, John.
John Curtis.
John, thank you. Just one moment. Anyone else on the phone and that wishes to speak to this? All right, we are going to alternate between going room and phone first. We're going to try. So, John, you are up now. Go ahead, sir.
Oh, for those who weren't present, John Curtis, Jackson and Josephine County's Disability Services Advisory Council. For those who weren't present this morning, word search for health literacy, I found it in 6C, and I would like to comment on that particular provision. I'm concerned about the 6th grade level of education or for reading education and whether that's a fitting level for especially those with limited English proficiency, particularly the deaf.
Okay, thank you, sir. Are you able to speak to the 6th grade?
Yes, I can speak.
Okay, John, our subject matter expert, Tiffany Regan, will speak to that at this time.
Thank you. That's actually in CFR, and so that's where 6th grade comes from.
All right, thank you for that. In the room, I think we had Robin from Umpqua, and apologies, who else did we have wishing to speak? And Sean from SEIU, and then Beth from OLC, and anyone that wants to get on board after that, including Dana. So we will start with Robin Traver from Umpqua.
So under section 7, small b, big A, I have a question. Is this referring to all languages or just prevalent languages?
I'll have to take that back. Thank you.
All right, Sean from SEIU.
Sean Parkman from SEIU, 503, thanks. A general comment, one specific example is in section 3. This is kind of thematic throughout the day, but kind of one more time. Information materials shall be sufficient. It's like, how do you know what's sufficient? So, and how would that be judged? So if this is the rules, we might need more specificity around what that means so that the rules can be correctly interpreted. And then around section 6, subsection B and C, it's my understanding that the intention here, I'm interpreting this as to be trying to reach the Oregon population that needs extra or different types of outreach and help to understand the complex world of healthcare and how to sign up and so on. And so with that in mind, I would recommend, a lot of this is about writing and reading. There's a little bit about oral presentation, what have you. I would recommend that you think about specifically calling out the role of community health workers or some other deliberate community outreach, thinking about communication to members and potential member information in a broader sense of not just like, it's on the website, but rather proactive outreach to communities that really need engagement.
Okay. Thank you for that. I think, and we may get there in later rules, Sean, I think we do make reference in one of the other marketing rules about traditional health workers, but if not, your comment is duly noted, and I thank you for it. We were going to go back to Dana Steringer, and then apologies for I seeing Jeremiah wanting to after Dana.
Yeah, just a question.
Okay, let's go to Dana, and then Dana, then Beth, and then Jeremiah.
Mr. Limit-Dill, I would just request that the rule be moving into potential member outreach. Since again, this is rule about the defined term you're talking about.
All right, thank you for that. Beth Englander from OLC, and then Jeremiah can ask his question of Tiffany. Go ahead.
Thank you. I don't have super strong feelings about this, but I'll just point out that marketing is also a defined term here, so, and it being more accurately described.
Okay.
What the rule's about. I'm going to just reiterate a comment that I made in response to the definitions section.
Okay.
Are we in? We're in 35A. Okay.
Yes.
Definition section. I think we should review and have a tribal liaison consult on use of the word Indian in this rule.
All righty, thank you for that.
I'm going to just right now just apply that to anywhere else that it's found, and so I don't have to keep repeating.
Sure.
And a quick question, if someone wouldn't mind answering this for me, if CCO is marketing or doing outreach, and someone wants to change their CCO, if they have an option in their region, is the CCO allowed to reject someone?
To give you a concrete answer, I honestly would want to go back and look at the spirit and intent of existing rule. I have most all of these proposed rules consuming my head at the moment, so happy to be something that we follow up with you.
We don't have anything to do with enrollment.
No, but we'll be doing the enrollment rules later in the week.
Just to answer a question, we don't have anything to do with enrollment, so
Okay,
it's
I
just
thought so.
DHS does.
Okay, that informs
Okay.
any other comments.
Okay. And then, so were we going to Jeremiah's?
Yeah, so Jeremiah again. Since there is a link between the fact that we're talking about outreach to potential members and it really close to the marketing definition, and to Sean's point, I think, and correct me if I'm wrong, we have to, for things going to potential members, we all have to, the determination is made by the agency. We have to send all of our materials to you all to make sure that they, so that's it's not, it's the agency who decides.
That's correct.
Yeah.
We have actually FTE devoted to reviewing member communications from CCOs and MCs.
Okay. Anyone else, either on the phone or in the room, wishing to engage on this particular rule? All right, we are going to move along to 410, 141, 3585, MCE Member Relations, Education and Information. The notable changes here are reference to the Ombudsman program, and I think I spoke to that Ombudsperson program, my apologies. I spoke to that, I think, earlier, that there was a requirement for CCOs to make individuals and consumers aware of the Ombudsperson program. Sorry, I worked in the Ombudsperson program for a number of years, and I'm still learning to say that correctly after all these years. Reference to the Ombudsperson program, intensive care coordination activities, and the availability of written materials in the prevalent non-English language. The notable change are in the following. The second half of number 3, starting with written materials including provider directories, and then 4C, inform members of the availability of the Ombudsperson program, and then 5A, the recognition towards the end of that sentence, as well as alternative formats. We'll pause, take a moment, and let people digest that and see if they have any questions or comments. Let's start with seeing who, if anyone on the phone as a RAC participant, would like to offer comment or question. Anyone?
John Curtis.
Go ahead, John.
To Rule 4B, where it talks about the certified and qualified healthcare interpreters, might it be appropriate to add certified medical interpreters?
Thank you for that comment. We will explore that, and I'm glad you actually pointed this out. This was the point that I would spot in the rule that I was referencing earlier as to the reference to the requirement to educate and inform about traditional health workers. But to be clear, your request is specific to certified interpreters. Is that correct?
Medical interpreter.
Certified medical interpreters. Thank you very much for that comment. We will take it under advisement. And anyone in the room? I'm seeing Michael Sorensen from Healthcare All Oregon, Healthcare for All Oregonians. Then we will go to Beth Englander, and then we will go to Dana Steringer. Can I just see by a show of hands, and Jessica Sayers from Pacific Source after that? Can I just see as a show of hands, and people may change their mind and wish to engage, but anyone else in the room wanting to get in the queue on that? All right, Michael.
Mike Sorensen, Healthcare for All Oregon. Looking at number 3, the MCE shall accommodate requests made for interpretation. The word accommodate is used here, and in the previous rule, the word honor is used. I don't know the difference between those two, between honor and accommodate.
Okay.
Accommodate request or honor request. I'm looking for consistency.
Okay. Thank you for that. We will evaluate that.
Hi, this is Beth from OLC. Please correct me if I'm wrong, but I don't think there's reference in this rule to education and information about the grievance and appeal process or about policies and criteria for approval for things that need approval. And I think there's been really a lot of inconsistency across the CCOs about how people can grieve something. And because the grievance system is a really main source of information that the health authority uses to track what's going well and what's not going well, I feel like that's a really, really important thing that people need education and information on. And I would love to see it in rule that the grievance process and form, even as informal as that, can be available on a website or to be sent out to people upon request.
Okay.
Am I missing it? Is it in there?
I'm skimming along as I hear you, and I am not seeing it, so.
And also education and information available on the website or in other sources for the criteria, for example, what flexible services would be considered, or how does a particular CCO decide what health-related services are going to be provided or approved. And other things where there may be variations from the standard prioritized list services.
Okay.
On what basis are the decisions made so people have access to that?
Okay, so I'm hearing a request for 2 potential additions to this rule. 1, that there be a responsibility to educate and inform about the grievance and appeal process, and 2, something that provides some meaningful context to the member about health-related services or flex services. All right, thank you for that. Got to respect the queue, but we will get to you as a follow-up if that works, okay? Thank you. And I think that we have Jessica Sayers from Pacific Source next.
Yeah, Jessica Sayers, Pacific Source. I have a couple of comments on section 5C. This is talking about the machine-readable file and format, and there's an example given of a PDF document. I recall last year it was clarified from the OHA that was not acceptable and that 508 and 504 compliance needed to be met, and a PDF was not sufficient.
Okay.
So I would like clarity there, and it is also restated in 6 little h, big E, I.
All right, we hear you loud and clear about the need to address the machine-readable format for clarification. And
one more.
And one more, go ahead.
Yeah, section 6, it talks about the provider directories. Under D and E, it says website URL and provider specialty as appropriate. I would be interested to hear what the OHA thought as appropriate means for us, because when we're collecting data, we need to know who to collect it on, who fits in that appropriate bucket. Okay.
And I do not have an answer at this time, but we will take that back and get back with you on that for full context. Let me just circle back around the room before we come back to Providence. I think Dana Steringer, were you Did anyone at that end of the table have their hand up before Providence wished to engage again?
A question about provider directories and under number 3, written materials, including provider directories, member handbooks, appeal and grievance notices. So the including provider directories is new language added, and I'm wondering what the where that's coming. Specifically, the handbook has been kind of the document that describes the process for most of these things.
So I can't provide the exact site, but I believe this is consistent with federal law and the requirements for inclusion of certain data points and elements in the member handbook and the format that it be made available. But I can.
But not for the provider directory.
Provider directory. We will go back and look at that. All right, and thank you for that. Providence.
Thanks. So I just wanted to check in with what Beth was saying and wonder how what she's asking for is different than what's required in section 10 sub N on page 4, little a, little b, or big A, big B under N. So starting at the bottom of the 3rd page.
Information
on the board.
So the intro for 10 is an MCE shall electronically provide to the authority for approval each version of the printed welcome packet that improves a welcome letter, member handbook, and information how to access a provider directory. At a minimum, the member handbook shall contain the following. So thank you for pointing that out. Beth, to you, does that meet the intent of the request that you were making?
Partially, thank you for finding that because I didn't.
Yes, thank you.
But one thing that I have noticed is that CCOs will have some information, but it'll be one sentence saying, call if you have a grievance for some CCOs. And other CCOs, it'll be a link to a specific form. And so I think there just needs to be more direct detail, making it very easy for people to understand how to file a grievance that doesn't involve calling and waiting on hold. I know that is probably the subject for the actual grievance and appeals CCO, but just in this member education section, I think it would be really helpful to reiterate that the process needs to be very clear and easily accessible. I would ask that it be more than just call a number. That is helpful to know that it's in there.
All right, thank you. All right, is there anyone RAC participant on the phone? Last chance to get in on this. All right, we are going to move along to 410, 141, 3590, Managed Care Entity Member Relations, Member Rights and Responsibilities. I believe minimal edits were made to this, specific to number 1, which I will let you read for yourselves. Any specific comments or questions on the phone specific to this proposed rule? All right, hearing none and seeing no hands go up, I'm going to move us along and offer the friendly reminder that people do have 7 working days should they identify something that comes of that. We have a couple options right now. We are actually making pretty good time. We're going to transition into the managed care assessment piece, and that was back to Measure 101 a number of years ago, and some changes to that rule that largely came from this legislative session. Those are fairly minimal in process and content. It is 10 after 1, so I will put to the group, 10 after 2 rather. I will put to the group if you wish to take a 10-minute break now, or if you wish to continue with this, and then we will come back and conclude. What are people's preferences? Vote to finish. All right, push on through. All right, with that said, we're going to move to 410, 141, 3600. This is managed care assessment definitions. There literally are no substantive changes. We are doing this in the name of transparency to show you that The only migration is the number of the rule and the categorizing, that all the rules in this series are assessment heading. All right, I'm going to move us along to the next one, 410, 141, 3601, MCE General Administration. This is where there is one of the material changes in this rule specific to number 2, 2A. That is that the assessment, or 2B rather, that based on the passage of legislation this year, that will go from 1.5% to 2, I'm sorry, yes, from 1.5% to 2%. Any questions or comments anyone would like to offer on that? In the room or on the phone? All right, next rule.
I'm sorry,
Sure.
Could you just offer an explanation and say, what do you mean by so classified?
One more time. I'm sorry, Beth, I'm just not hearing you.
Can you use your mic, please?
I'm sorry, I forgot. Could you just
For those of us not well versed in assessment, could you just explain what do you mean by so classified? Information or statistics so classified?
And can I ask where specific?
Oh, 2B, is that?
I'm on 3601, I'm sorry.
Sorry.
It's okay, not a problem. So this is really an increase in the assessment based on legislation from the 2019 session. I will move us to 410, 141, 36015 MCE Assessment Disclosure of Information. There are no substantive changes to this rule, nor are there with 410, 141, 3610. That is the assessment calculation report and due verification. I will continue by telling you that 410, 141, 3615 MCE assessment filing and amended report, there are no substantial changes there. Again, we were doing this to make sure that you know that we are not trying to alter or change any rules without doing so through a transparent rulemaking process. 3620, determining the date filed, no substantive change. Similarly, 3625, no substantive change. Again, when you go back to your respective shops, CCOs, if you speak with your financial people or there are issues or concerns you wish to bring up, you may do so within the next 7 calendar days. Same thing with 410, 141, 3635, 410, 141, 3640, 410, 141, 3645, 410, 141, 3650, 410, 141, 3655, and now we will move into our final piece of substantive conversation today for this RAC, and that is discussion around 410, 141, 3700. That is the CCO application and contracting procedures. This rule was significantly consolidated and streamlined. There are the inclusion of the following local definitions: applicant, application, and the relocation of the definition of RFA, or request for applications, to this as a local definition. Those are all identified in 1, and there is an inclusion in 2E noting requirements of 410, 141, 3705 on this. We will open for questions and comments. May I ask if anyone on the phone wishes to offer comment or ask a question specific to this proposed rule change? I'm seeing 1 hand in the room so far. 2 hands in the room. Let's start with Robin Traver from Umpqua.
You might have clarifying questions, and I would have to get back to you on this.
Okay.
But our COO asked regarding Section 2, if the RFA is going to comply with ORS 279A and B and OAR 137-047-0600.
137, can you give me the ORS number again?
Oh, yeah, the ORS is
279A and B, and then the statute, the rule, sorry, the OAR?
Is 137-047-0600. 0600.
And we will look at those and follow up with you. Are there any other individuals in the room wishing to ask questions or offer comment? And at the end of the table on this side, and then Jeremiah Rigsby. And sorry, not a hot mic. Can you
hear me now?
Yes, thank you.
Jessica Lundgren, Cedar Hills Hospital. One more time about IMD inclusion.
Okay. And can you frame that, state that again for us as a question or offering a comment? I'm sorry.
I think I'm going to have to take that back and get a little more information.
Okay.
Yeah,
all right.
Okay, thanks.
We welcome that. Thank you. And did I see a hand from Jeremiah?
Jeremiah Rigsby, I know you have to, looking at section, let's see, where it's talking about Warprint, I think that's 2B. I know you have to use Warprint. We've had some trouble having only a few people that have logins to Warprint, and then information was coming out a lot of different ways, so we didn't know where to be looking first. And I would only, just a comment would be helpful if there was if it's a public notice, that public notice also gets put on a public website and directs people kind of what the process is, just because limited access to Warprint, everyone was getting a bunch of information from different places.
Gotcha. Thank you for that. All right. Any other comments or questions specific to this rule? All right. Given we did not take a break, I did not have opportunity to solicit from our participants in the back of the room that are here as the public attending, if anyone in the back of the room wishes to offer public comment, or any individual on the phone. Can we do a check-in of people on the phone that are not RAC participants that may wish to offer public comment today? May I do a check-in in the back of the room and see by a show of hands if anyone wishes to offer public comment? All right, no public comment being offered today. We are adjourned at 2:15. We thank you for coming today, and we look forward to seeing many of you tomorrow morning. Have a good rest of your day and a great evening. Thank you.